Good afternoon. I'd like to thank SAGES for allowing me to present on gastric bypass revisions. Can endoluminal approaches avoid surgery? My name is Bipan Chand. I'm the Regional Director of Bariatrics at Loyola University in Chicago. I have no disclosures for this presentation. My objectives are to go over weight loss results of commonly performed surgical procedures. How do we define weight regain or suboptimal results? How should we then evaluate anatomy, particularly for gastric bypass, and what options can we offer, particularly with endoluminal approaches? I think it's important to remember that all bariatric operations have the potential of weight regain and the development of complications or return of disease states, particularly with weight regain. It's important also to remember what are the long-term results of these different operations we offer our patients. Long-term results with gastric bypass with greater than 10 years from the index operation shows a mean weight loss here of approximately 60% of the excess body weight loss, while the duodenal switch remains a more efficacious operation with approximately 70% excess weight loss. The sleeve gastrectomy is relatively newer, and we have less results on long-term weight loss. However, most studies have shown the efficacy to be similar to gastric bypass. And if you look at pooled results with most papers, you'll see that the weight loss averages between 50 to 60% excess weight loss when measuring at greater than 10 years. So how do we define weight regain or suboptimal results? I think it's important for all of us to remember the definitions are somewhat challenging, but for weight loss, there is already some consensus to use the percentage of total weight loss reporting weight loss outcomes. Weight regain should be quantified as a percentage of maximum weight loss and has the strongest association with the development of clinical comorbidities. So gaining weight after bariatric surgery can be classified into either weight regain, which is defined as a gain of 20% of the maximum weight loss, or inadequate weight loss, which is defined as less than 50% excess weight loss. And in studies, weight regain has been reported as high as 25 to 35% of initial excess weight loss, which typically occurs within the 2 to 7 year post-op timeframe, particularly for gastric bypass. It's important to remember what we're doing in gastric bypass. The obviously approaches of these operations are typically laparoscopic, and the goal is to both have gastric manipulation and an intestinal reconstruction. There are variations to this operation. However, the goal again is to create a gastric pouch that is relatively small in size, based off the cardia with no communication to the gastric antrum. The gastrojejunostomy is typically created in multiple different fashions, either using a hand-sewn technique, linear staplers or circular staplers, and the distal anastomosis can vary in lengths of the biliopancreatic limb as well as the common channel. But in essence, when you create this reconstruction, our goals are a small gastric pouch with a small outlet and a roux limb that is approximately 75 to 150 centimeters in length. Endoscopically, it's also important to remember what the normal anatomy should be in gastric bypass. In this video of a patient undergoing an endoluminal intervention, we're evaluating the gastric bypass anatomy, and the best is to measure the distance from the esophageal-gastric junction to the gastrojejunostomy, try to measure the outlet size as demonstrated here, try to determine the length of the candy cane or the blind end of the small intestine. Here we utilize a snare to measure the size of the anastomosis. In this particular instance, the anastomosis is approximately 1.5 centimeters in size, which is an acceptable size of an anastomosis. Other imaging modalities, including upper endoscopy and CT scans, can allow the surgeon to evaluate the anatomy, and particularly looking for fistulas between the gastric pouch and the gastric remnant, as well as a long candy cane limb, as well as distension of the gastric pouch. However, these imaging modalities have limitations when trying to determine the size of the stoma. So what anatomy is considered abnormal after gastric bypass? Most look at the gastric pouch, both in descriptions of the width as well as the length, as well as the gastrojejunal diameter. is more challenging to measure rule limb lengths, biliopancreatic limb lengths, and the common channel length, both on endoscopy as well as imaging. Gastrogastric fistulas can readily be picked up on both endoscopy as well as on upper GI studies. The literature has defined an enlarged gastrojejunal anastomosis as greater than 2 centimeters and an enlarged gastric pouch measuring greater than 6 centimeters or a width greater than 5 centimeters. Again, the literature also shows that restrictive procedures, if they do fail, they can show both a pouch and a stoma dilation. And if you do offer a reduction of the gastric pouch or the gastric stoma, that has been shown to induce weight loss once again. Also, abnormal post-roux gastric anatomy was identified in a number of patients referred for investigation of weight regain. Our group looked at patients that underwent an endoscopy for a multitude of different regions, and about 70% of patients had an abnormal pouch and or stoma dimensions, with stoma measuring greater than 2 centimeters and a pouch measuring more than 5 centimeters in width. And these patients that underwent revisional procedures secondary to this anatomy were able to reinitiate weight loss in greater than 3/4 of these patients. If you look at the different sizes of both the stoma as well as the gastric pouch, our group identified that patients were found to have abnormal both pouch and stomas in approximately 30% of the time, and that the stoma was more influential in weight loss in comparison to the gastric pouch size. So what are the therapies that we can offer endoluminally? There's a multitude of different therapies that have come and gone. The ones listed here, including sclerotherapy, the barred endocinch device, the StomaFix, the incisionless operating platform, are therapies that are no longer available. The more common therapies include over-the-scope clips, over-stitch endoscopic suturing platform, and the argon plasma coagulation. And I'll go over these in a little bit more detail. Sclerotherapy, as depicted here, includes injecting an agent within the gastric submucosa at the site of the anastomosis. Here they're utilizing sodium laurate to inject around the stoma, and you can see depicted in images A and B that there is a marked reduction of the stoma after injecting this sclerosing agent. In this small study that I evaluated approximately 380 patients, 82% of the patients stabilized their weight with a weight loss of approximately 11 pounds or 5.3 kilograms. This therapy is simple and easy to use. It has few complications and is very repeatable. However, there is limited efficacy with short-term follow-up and is not readily available. The incisionless operating platform underwent an evaluation. The procedure included a Rose procedure, which is restorative obesity surgery done endoscopically. In this procedure, utilizing multiple pledgets, suturing at the gastrogenostomy. In this registry of close to 96 patients, the percent excess weight loss at 1 year was approximately 18%, with the overall percent of weight regained lost being 32%. It's acceptable weight loss. It does have a higher degree of full thickness, offers both a gastric pouch and gastrojejunal reduction with very few complications. However, it has short follow-up with very few studies and is currently not readily available. The over-the-scope platforms include the Ovesco as well as the Apanos. In this depiction here, you're utilizing a device that literally fits over the scope, much like a band ligator, and it approximates tissue utilizing this metallic device. There have been limited studies. However, the studies that are available include this one here with 94 patients with weight regain after gastric bypass. The focus was on gastric pouch outlet reduction. And as you can see, the BMI loss after 3 months and 1 year from a starting BMI of 32.8 down to 27.4 at approximately 1 year of follow-up. This is acceptable weight loss with an improvement in the gastrojejunal diameter reduction with minimal to no major complications. However, there is short long-term follow-up with limited data, and it is technically somewhat challenging and dependent on the type of the anastomosis and the configuration of the anastomosis. The most commonly used device endoscopically after gastric bypass includes the overstitch endoscopic suturing system, as depicted here. This is developed by Apollo Endosurgery. This is a somewhat more cumbersome device, however, does allow for both gastric pouch and stoma reduction. As depicted here, you can see a stoma on the bottom that is prior to suturing and then one subsequently after. There's multiple papers published on this technique, including variations of the technique, as well as the addition of using argon plasma coagulation to increase the efficacy of the therapy. And there are multiple publications as listed here with numerous patients have shown a mean weight loss at 12 and 24 months of approximately 8.4 kilograms. This is an acceptable weight loss. It does offer full thickness, larger and deeper purchases than other devices that had been on the market. The focus is typically on gastrojejunal diameter reduction with few complications. However, there is, again, short-term follow-up with limited data. Argon plasma coagulation, as depicted here, it has also been tried in reducing the size of the stoma. The variations in these pictures here from the image 1 to 4, the goal of the therapy is to apply the argon at the anastomosis, inducing a fibrotic reaction, thereby scarring the anastomosis. There have been some studies on this. This is a prospective, no comparison, of approximately 30 patients. Each of the patients underwent approximately 3 sessions that were set apart by 2 months. And the final results at 8 weeks after the 3rd session shows that the body weight did change. And you can see in this depiction, the weight loss mean was approximately 15 kilograms of the 19 kilograms of the weight regained after gastric bypass. However, it did include 3 sessions. So argon plasma coagulation is acceptable weight loss. It's simple, it's readily available. There is an attempt at a GJ reduction with few complications. Again, there is short-term follow-up with limited data. Recently published was an endoluminal revision of gastric bypass for weight regain by the ASMBS task force. I think it's important to remember when you look at weight loss and a therapy to induce weight loss, you're able to measure it in different parameters. Endoluminal therapies have been shown to be safe, technically feasible, as well as allowing repeatability. However, the question is always efficacy and durability of these therapies. These are the therapies that we went over that hopefully look at those parameters. Endoscopic therapy versus surgical interventions has also been evaluated in this study of 24 studies with close to 900 patients. They evaluated surgical as well as endoscopic approaches, with endoluminal procedures being the torus, the rose, the sclerotherapy, as well as gastric plication and suturing. And as you could expect, the weight loss varied from all of these different therapies, with the highest efficacy being conversion of gastric bypass to duodenal switch compared to distalizing the gastric bypass, compared to banding over a gastric bypass, to surgical revision of the gastric pouch, to endoluminal revision of either the gastric pouch and the gastric jejunostomy. I think it's important for the audience to remember overall the efficacy will be less with endoluminal therapies. However, the major complications will be the lowest with endoluminal therapies as depicted here. My last slide is to talk about the management of gastric bypass, and is endoluminal therapy important in timing of the intervention? My belief is that if we intervene, in particular with endoluminal therapies, the typical time to intervene should be earlier, when patients are starting to see an increase in their weight, which is typically seen between 2 and 5 years. If you're intervening at this intervention in time, you may have greater efficacy in your endoluminal therapies. In summary, understand how to define inadequate weight loss and weight regain. It's important to utilize imaging, in particular upper endoscopy, as well as contrast and CT imaging to understand some of the failures or suboptimal results of your anatomy, in particular with gastric bypass. Do a multidisciplinary approach for each of your patients and know the tools that are readily available for endoscopic management. Thank you very much.